Hello. The clinical interpretation of cytologic results is essential for doctors who conduct FNA, but it's too vast. So I'm thinking about how to proceed, and I'm going to look at this case and start. A 31-year-old woman found a suspicious thyroid nodule in an outside clinic. Ultrasound showed solid and hypoechogenicity, so it is at least categorized as K-TIRADS 4. In my view, it was judged as K-TIRADS 5 because it was taller in the transverse scan. The size was 11 mm. FNA was performed at an outside clinic and diagnosed as nondiagnostic. She was told to do FNA again after 6 months at the clinic, but the patient changed the hospital after hearing that there was a lack of cells. This is an ultrasound performed by my hospital. Although a radiologist who performed FNA was experienced, the non-diagnostic results came out again. The examiner asked me how to manage this nodule. I asked the doctor if there were any old ultrasound images. Doctors often explain non-diagnostic results as lack of cells or not enough cells, which is an incorrect explanation. Explaining insufficient follicular cells is an accurate description of the non-diagnostic results. When the FNA result is non-diagnostic, both doctor and patient are embarrassed. From a patient's point of view, the FNA was painful, expensive, and time-consuming. Therefore, if they heard that the result was a lack of cells or insufficient cells, many patients felt something was unfair. The unfairness is likely to turn into a question of whether the examiner has properly done it. What are the doctor's thoughts? If the doctor doesn't have a sufficient understanding of the interpretation of the cytology results, and the doctor is an inexperienced one doing FNA, he or she may suspect oneself and feel guilty feeling, even though he or she did a good job of testing. Or if the doctor who is explaining to the patient is different from the doctor that is performing FNA. The explaining doctor may have doubts about whether the examiner has done the examination properly. Therefore, we need a good understanding of the results of the cytology. Tumors are basically characterized by heterogeneity. Cancer is not composed of 100% cancer cells. It's made up of quite a variety of cells, like a schematized figure. Therefore, it is essential to do to and fro motion in various directions when doing FNA. If the direction of FNA is only in this way, you cannot get cancer cells even though it is a cancer. This tumor is benign. In the case of a benign nodule, it tends to be more difficult to diagnose it in FNA. Now, let's take a brief look at the history of cytology interpretation at a thyroid nodule. Various analyses by the human eye are subjective. Before the implementation of the Bethesda system, a lot of descriptive reading was done. Therefore, even if somebody read very long sentences carefully, it was not easy to judge what the conclusion was, because the terms and judgments used by each cytopathologist were so diverse. In 1997, the Papanicolaou Society suggested that cytologic results be categorized like the Bethesda system. However, it has not been commercialized. In 2002, Ortel, a famous pathologist at the University of Washington, said that there are many differences of opinion between pathologists, even in the same terminology. Now let's talk about the criteria of non-diagnostic in the cytology. Several studies suggested that benign cytology should be at least 6 groups with at least 10 benign follicular cells. The Bethesda system uses the same criteria with some exceptions. In 2006, a survey was done on pathologists. When asked about the adequate specimen criteria, 40% of pathologists said the current criteria were appropriate, and 23% said it was okay up to 5 groups. In 2017, there was also a discussion about the criteria of sufficient cell count in the Bethesda system, 2nd edition. The reason is that the great majority of non-diagnostic nodules prove to be benign. And lowering the criterion of sufficient number of cells has the effect of lowering repeat FNA. However, there had been no consensus on a lower number. However, even if the number is not satisfied, if the colloid is abundant or a small amount of atypical cells is visible, it is defined as benign and atypia, respectively. Although the number of cells could not be lowered, the cystic nodule without bad findings on ultrasound could be treated like a benign nodule. Even if the FNA is properly progressed, there is a high possibility that there are not many follicular cells in the nodule itself. In most cases of cystic benign or mummified nodules, there are likely not many follicular cells. Now let's look at the case again. The top is images of the outside clinic 4 months ago. The bottom is images of my hospital. The ultrasound feature of the nodule seems to have gotten worse, but the size has decreased slightly. Cytologic results of the nodule were non-diagnostic twice. Like this case, if a nodule shows suspicious US features, decreased in size, and repeatedly indeterminate cytologic results such as non-diagnostic or atypia, you should consider it as a mummified nodule. Then, you do your best to get the old US images. These are images from the nodule 9 years ago. As you can see, this nodule does not have any suspicious US feature. You can see the process of mummification. This is a benign mummified nodule. Thank you.